All right, another live session here from Omaha Spine and Sport. I'm Dr. Peters, this is Dr. Campbell. Today we're going to be talking about the assessment and treatment for knee pain, whether that's patellofemoral pain, IT band syndrome. We see a lot of that. We treat a lot of runners. So we'll start with the assessment. Just before we get into that, a little bit of intro on knee pain. It's actually the most common condition with runners. A lot of people want to talk about plantar fasciitis, foot pain, which we'll get to later. We just did a recent talk with Red Dirt Running Company on that. But knee pain is by far and away the most common. 25% of runners will have a knee complaint annually, so it's a pretty big deal. We see a lot of it in the office. And it's also, if you've had an x-ray or anybody tell you, 85% of people that have knee arthritis on x-ray actually have no knee pain. So it's not the x-ray, it's a functional cause. We'll kind of talk about some of the function or dysfunction that we look for, and then how we handle that from a treatment standpoint.
One of the common misconceptions with knee pain is that everything's about the knee, and we try to retrain strength in the knee. We used to do a lot of like patellar tracking treatment, which we found out is completely kind of a waste of time. Like to change patellar tracking is actually really difficult to do because, like Jace said, the knee is kind of the middle child. It gets blamed for everything, but it's really not to blame. It's really not the one doing the actual damage. It's the problem proximally with the hip and then distally with the foot. So it's kind of caught in between these two really important spots in the musculoskeletal system, and really the treatment should be aimed at the foot and ankle and the hip, because that's really what controls the knee. The knee can only do what the hip can control and what the foot and ankle will allow for. And so if we don't assess those two areas, then we're really kind of missing the boat on knee pain. And like Jay said, most common complaint in runners is knee pain, because those two areas, and running being primarily a straight ahead, right in front of you sport, we don't really actually get into these other planes of movement that's required to activate the hip musculature and to force the foot to move a little more naturally. So if you're dealing with knee pain, just make sure that these other areas are getting assessed, because it's really not the knee's fault. It can only do what these other two places can control. And so if you're just doing like knee strengthening stuff, that's important, but it's probably not like the key to helping your knee pain resolve or stay resolved once you get it feeling better. So we're going to go through the assessment. Jason's going to talk about how we assess for knee pain.
All right. Like Corey said, you actually see a discrepancy. You see too much frontal plane motion at the knee. If you picture yourself running, if this knee is kind of diving all over the place, it's more likely to irritate that patellofemoral joint or the IT band. So one of the tests that we use is we actually assess it in single leg stance with the 6-inch step down. So all I'm going to do is I'm going to nice slow and descend and try to control and touch the heel. Obviously we don't tell our patients how to do this, we just watch them complete the movement. And what we see a lot of the times is this. Right? It's very difficult for them to control because they lack the proximal hip strength to be able to control their legs. So you'll see this diving all over the place. You see it on the other side.
When we talk about knee injuries, like the ACL and those kinds of things, this is one of the tests that we have to do. Obviously with ACL injuries, there's other things that go into that, but this is one component of an ACL injury. Most ACL injuries are non-contact, and it's that landing phase and this uncontrolled, what we call valgosity, or this diving in of the femur and putting stress through the knee. So those are one of the things that we look for. Another thing we'll see with this test is we'll see him turn the foot out to do this, which basically is just cheating one motion for another. That usually tells us that there's something going on in the foot and ankle that's not working right.
All right, so you actually see less hip abductor and external rotation strength in people with patellofemoral pain and knee pain, and then that's why we're mostly focused. It's the middle child between the hip and the ankle, and I love that analogy because I'm a middle child and we're never the problem. It's always the older younger sibling. So now another one that we like to use is the modified Thomas test. So I'm going to switch the camera just a little bit so you can see Corey. Perfect. So we have him off the end of the bench. He's just going to grab one leg, let this other one relax. So here we're assessing hip flexion. We have quads, tightness if this leg's not back, and then you also can see the IT band. You'll kind of see that foot flare out here. All right? So this is a really good test that we use. We'll assess it both sides and then kind of target our treatment towards the assessment. So with Corey, a little bit of hip flexion. We have a little restriction here. That's going to affect how that hip works and the ability to control this knee. So we'll assess the other side, just have them switch. Same thing. So assess that. You'll see a lot of times you can even palpate the IT band over here, and you can just feel, you'll be able to feel the tightness. And like I said, with everything that we do here, the assessment is always going to dictate the treatment. All right, so have Corey slide back. Another very kind of commonly missed part of the assessment is the proximal fibular head. So if Corey rolls up his pants just a little bit, it's just that little bump on the outside of your leg, and we want to be able to palpate and make sure that has good joint play. It's a subtle movement, but it's very, very important, okay? We're going to palpate that, make sure that's moving correctly. A lot of times, all that is just a mobilization here. And like we said, with the middle child, the foot and ankle is very, very important. So we'll always palpate the foot and ankle. If you have a very, very flat foot, that foot is going to actually drive your knee into that valgosity, which we don't want. It's more likely to irritate the patellofemoral joint or the knee. And on the flip side, if you have a very, very rigid foot, well, then you have troubles dissipating forces. So every time you hit, every time you pound, all those forces go up, and it puts a lot of force at the knee. There's studies that say if you cue runners to run quicker, faster, and lighter, it actually decreases the amount of force that goes to the knee. So that's something that we use, a quick fix, for runners to work on increasing their cadence by like 5 to 10%, which isn't a lot, and it'll actually decrease the amount of force here through the knee. Okay? It'll put the forces up in another spot, but hopefully that spot can handle it, and it gives the knee a little bit of a break. So palpate the foot and ankle. Is that all we got for the assessment? Yeah.
Internal hip rotation.
Oh, and then we always end with the internal hip rotation, because the ability, which I'm not imagining we'll see it in Corey, we generally see this in females, so we'll have them lay face down, and then we're just going to let this leg come out. And the amount of internal hip rotation kind of puts us down a path of whether we have a stability issue or a mobility issue. So if it's a stability issue, this leg, which you can't really see very well, will fall all the way out to the side. I'm going to do it on the other side. So we're here, and then I let Corey come out. So this is more of a mobility issue. Corey needs mobility into this right hip. If it was a stability issue, you'll likely see this come all the way out like this. Okay, and then that tells us that this hip needs a little bit more strengthening, stability, hip abductor, hip external rotation, stability here, and then based off of what we palpated at the foot and ankle will kind of tell us whether it needs adjusting or some strengthening.
So what do we do for treatment? What do we do for these findings? Let's talk about the mobility part first. We can just have Jason, that same modified Thomas position here. Yeah, we'll just go this side. We can either do what we call post-isometric relaxation. You guys can't really see me. No, I'm in the camera. Where we would actually do some light lengthening. If we want to affect trigger points and muscle length, then we have to use what we call muscle energy techniques or light post-isometric relaxation type techniques to get length in the muscle and change trigger points. The other way we can change trigger points is with needle or with ischemic compression. We can't do it with myofascial release. But that's also part of some of the, let's take this table down so we can see a little better. That's part of the assessment and treatment of this, is that we actually have to get into some of these hip flexor muscles and see if we need to break up the adhesions in the muscles. And we can get adhesions here in the hip flexors and closer to the hip. We can get them clear out here. If you have knee pain at the knee itself, then one of the muscles that attaches into the knee that can cause a lot of problems is the rectus femoris, which is this big, long quad muscle. So we have to assess that and see if there's adhesions through there. And the only way we can do that is with our hands and kind of palpate and feel for those spots. If we find those spots, then we do a myofascial release, and we just break that stuff up. But if we want length, then we have to pick a different tool. So we just have to make sure we pick the right tool for the job. The other thing that we need to do is, if we're looking at mobility issues, is obviously the foot and ankle. So we'll look at the different ways that we can assess the foot and ankle. Jace talked about how we palpate it. Two key areas of the foot and ankle is the midfoot. So from this little bone on the outside part of your foot to this big kind of keystone of the arch, which is the navicular, right in the middle of the arch. We can either mobilize this or we can do manipulative treatment. We have some really gentle ways to do that with these little speeder boards where we can actually mobilize the foot and ankle. to get the motion that we need in there without a lot of pain to the patient. It makes a lot of noise, but its bark is a lot worse than its bite. It actually doesn't hurt. Most people say it feels good. That's one area we need to look at. And then the most important area of the foot and ankle, in runners especially, is the subtalar joint, which is this funny little joint that's unlike any other in the body. It's in the back part of the foot here. It's where your heel meets the next bone. This is our main shock absorbing mechanism in the foot and ankle and in the lower extremity. Probably, arguably, the most important shock absorbing mechanism that we have in our body. We have to be able to mobilize that and make sure that that's functioning correctly. Like Jay said, in somebody with a hyperpronated foot, we're not doing this kind of work with them because they need more stability than they do anything else. But surprisingly enough, pronation isn't going to be the end of the world like some people would make you believe. When we assess people here, I would say it's close to 50-50, maybe even a little bit more shaded towards the rigid foot, which is just as detrimental to the knee as the hypermobile or pronated foot. So we have to assess that and make sure that we're plugging in the right treatment. If we have a stiff foot and we're trying to give them a bunch of stability exercise for the foot, that's making a hard structure even less flexible. And so the forces that we have to absorb, which during running can reach 6 to 8 times our body weight, is not going to be able to handle that. So we have to make sure that we're plugging in the right treatments. From a stability standpoint, then we have some other things we need to do more from an exercise standpoint. So let's have you come up. We can do some hip strengthening things, but we would start more baseline than what you're going to see here. We would start with, if you visit our YouTube channel, you can see the clam exercise and the bridging exercises. Those are some baseline exercises to give us some hip stability. And when you do those exercises, it's not about strength, it's about control. So it's like slow controlled movement against resistance to build in 1, endurance, and 2, control or eccentric control. But some things that we can do from just some other things we can do that's a little more functional for you runners is we can do kind of a hip hinge with some resistance. So I would actually pull on the knee here, he would resist me, and then he can actually sit back or move forward in different planes while he's adding resistance or giving me some resistance to the knee. Another thing that we can do is right here at this edge of this table, we can do almost like a pigeon pose where we sit back into the hip, stay upright with the torso, and then shoot straight up towards the ceiling. And it's this slow, controlled movement on the way down that's important because it's that eccentric phase that we don't have. It's not so much this up and down part, it's this eccentric phase that we don't have when we're running. It's that side-to-side movement in the hip where we lack the control, which is what allows the femur to slide inside, which puts stress on the knee. So those are some things that we can do, and we can get really creative with these things. We can add resistance loops to the knees and make you walk sideways, which is called a monster walk, or we could add hip hinges. We can do knee sliders. We can do all sorts of different things with the exercise ball against the wall so that it looks and smells like running. We can do some of the 6-inch step down things with some resistance. There's lots of things we can do, but we have to start kind of baseline, build a foundation, and then we can get more creative as we go. But if that foundation isn't there, then we're actually going to strengthen bad patterns, and we'll probably make the knee pain worse if we plug in too many exercises at once. Anything to add?
And of course, we all, I would say as chiropractors, we will address the joint dysfunction. So a lot of times you'll see lumbopelvic joint dysfunction, so we'll be manipulating the low back, the hips, along with the foot and ankle if necessary. So I think that covers it. That's knee pain assessment and treatment with Dr. Corey Campbell and Dr. Jace Peters here at Omaha Spine and Sport, 156th and Pacific. We're right next door to Mama's Pizza. A lot of races coming up. We're helping out with the Good Life Halvesy with Red Dirt. I'm actually running this year, my first ever half marathon. So if you need any help with assessment and treatment of knee pain, you know who to call. 402-933-4447.
If you're running and have any questions, get a hold of us or Red Dirt. We're happy to help. So we'll see you next Wednesday. Thanks.